Welcome back to the deep dive. We are jumping straight into a pretty dense stack of source material today. It's all comprehensive clinical notes on dermatology.
Right.
But we're not just, reading a textbook here. We're really trying to pull out the high-stakes stuff, the nuanced knowledge that, well, it separates routine care from expert diagnosis.
Exactly. Going beyond just the surface level.
Yeah, exploring the sophisticated management protocols, looking at drug contraindications that carry some serious risks, and those surprising systemic links where the skin is actually giving us the first clue about an internal disease.
That's the fascinating part, isn't it? And for you listening, our mission today is really to cut through all that clinical jargon. We want to distill this layered info into things you can grasp instantly. We're hunting for those aha moments.
The key connections.
Yeah, the vital association clues, the specific drug regimens you absolutely have to follow. By the end of this, you'll have a much, much deeper appreciation for why dermatology is often that first window into someone's overall systemic health.
Okay, let's unpack this straight away. Starting with maybe one of the most common conditions, but one that's still clinically complex, acne.
Right.
And specifically, the most potent tool they have, oral isotretinoin. Now, this isn't something prescribed lightly, is it? The notes make it very clear there's a high threshold.
Oh, absolutely. You don't just jump to isotretinoin. The main trigger, the reason you'd start considering it, is severe nodular acne. And crucially, acne that's leading to scarring.
Ah, the scarring is key.
If that irreversible damage, the scarring is happening, then the potential benefit might start to outweigh the pretty significant risks.
Okay.
But once you make that call, the clinical protocol gets incredibly strict. And that's because the drug is so potent and has all these systemic effects.
Let's dig into those requirements then, because it sounds like it's way more than just checking the skin. What kind of internal monitoring is needed?
Yeah, central monitoring involves regular checks on the patient's lipid profile and their triglycerides.
Lipids and triglycerides. Why those specifically?
Well, isotretinoin is lipophilic, meaning it interacts with fats. And it can really impact fat metabolism, sometimes causing, clinically significant hypertriglyceridemia.
Which carries its own risks, right? Cardiac risks.
Exactly. So you have to watch that. And beyond the lab work, the patient needs really detailed counseling. There are common side effects, usually manageable, like dry mouth and lips.
Oh.
Almost everyone gets that.
Okay.
But here's where we hit a really high-stakes drug interaction.
Right. This is the one with tetracyclines, I think, which are often used for less severe acne.
Precisely. Combining oral isotretinoin with any tetracycline medication can cause a condition called pseudotumor cerebri.
Pseudotumor cerebri. Sounds serious.
It is. It's basically increased pressure around the brain, mimics a tumor, causes awful headaches, vision changes. So the importance of this interaction means you must completely stop any tetracycline before even starting isotretinoin. It's absolutely non-negotiable.
Wow. Just knowing that connection is a huge safeguard for prescribing and diagnosis. And then, of course, there are the reproductive warnings, especially for female patients.
Oh, they define the entire process.
Yeah.
The drug is severely teratogenic. It causes major birth defects.
Okay.
So for any woman who could potentially become pregnant, the notes demand using 2 separate effective forms of contraception, starting before treatment even begins and continuing for a period after stopping.
2 forms. That's rigorous.
It has to be. And clinicians also need to counsel patients about other significant, though maybe less common, systemic issues. Things like photosensitivity, getting sunburned easily, potential hair thinning, that's alopecia, and there's a recognized, though kind of complex, link between retinoids and depression.
So these aren't just minor footnotes.
Not at all. They're part of the essential daily conversation needed to manage this drug safely.
Okay, that really paints a picture of the sort of extreme end of acne management. If we step back now to managing mild or moderate acne, the notes seem to lay out a very structured step-by-step approach. How does that latter start?
Right, it starts much more gently.
Sure.
The focus is on getting the most out of topical treatments first. So step 1 is usually either a topical retinoid like tretinoin,
Okay, right.
which helps with comedones and skin cell turnover, or you could use topical benzoyl peroxide, which is mainly antibacterial and also helps break down comedones.
So one or the other to start. What if that initial topical approach doesn't work well enough? What's step 2?
This is a really critical point where we bring in systemic treatment. Step 2 combines the topical therapy they're already using plus an oral antibiotic.
Oral.
Yes, oral. And the notes specifically say to avoid topical antibiotics at this stage.
Oh, interesting. Why avoid topical antibiotics then?
It's mainly about reducing the risk of creating bacterial resistance right there on the skin surface.
Ah, makes sense. So which oral antibiotic is typically used?
The standard choice here is an oral tetracycline, and it's usually prescribed for about a 3-month course.
3 months. Is there a specific reason for that time?
Yeah, 3 months generally gives enough time for the antibiotic's anti-inflammatory effects and its effect on bacteria to really show, but it also minimizes, long-term exposure.
Okay. And if 3 months isn't enough,
You might switch to a different oral antibiotic, maybe another one in the tetracycline family, for another 3 months. But there's a really important restriction here.
which is?
Avoid all tetracyclines in kids under 12. Big risk of permanent tooth discoloration.
Right, I remember that one. Okay, so let's say we've hit the 6-month mark using oral antibiotics, and for a female patient, things still haven't improved enough. What's the next move, according to the notes?
That 6-month point is a key decision moment. It suggests the underlying issue might be hormonal.
Hormonal. Okay.
So, for female patients who haven't responded adequately, the next step is usually prescribing the combined oral contraceptive pill, the CoCP.
The pill.
Exactly. The thinking is that CoCPs can reduce circulating androgens, those hormones that stimulate sebum production, so it tackles a potential root cause.
And only if that doesn't work.
Only if the acne still doesn't improve after a decent trial on the CoCP regimen.
Mm-hmm.
Then you make the formal referral to dermatology,
Mm.
and that's when they'd likely consider that oral isotretinoin we started with.
Got it. That's a very clear pathway. Okay, moving from chronic stuff like acne to more acute problems. Let's talk about distinguishing between two skin infections that sound similar but are different. Cellulitis and erysipelas.
Ah, yes, a very important distinction.
The difference sounds pretty fundamental for treatment.
It absolutely is. The difference really comes down to depth, and that depth dictates the severity and treatment.
Depth, okay.
Erysipelas is more superficial. It's basically confined to the epidermis and maybe the very upper part of the dermis. Clinically, it often looks quite sharply marked off, raised, and very red, like a clear border.
Okay, superficial, sharp border, and cellulitis.
Cellulitis goes deeper. It involves the dermis and the subcutaneous tissue underneath, so it tends to look more spread out, less sharply bordered, and carries a higher risk of spreading systemically.
Right. And the treatment section for cellulitis in these notes, wow, it's got really specific drug choices based on where it is on the body and the patient's situation. Why does location matter so much?
Location is huge, especially if it involves the face,
The face, why?
because facial cellulitis means the infection is anatomically closer to the cavernous sinus and the central nervous system. The risk of serious complications is just higher. So facial involvement needs a broader spectrum antibiotic to cover potentially tricky bugs. That's why it mandates co-amoxiclav.
Co-amoxiclav for the face. That makes total sense, higher stakes. What about adjustments based on the patient?
Right. If the patient is generally okay and the cellulitis is somewhere else, like a leg,
Standard case.
yeah, then flucloxacillin is usually the go-to.
Yeah.
But if the patient has a penicillin allergy, you have to switch, usually to clarithromycin plus metronidazole to get adequate coverage.
Okay, allergy alternative.
And then there's the critical scenario of pregnancy. If the patient is pregnant, you have to choose something with a known safety record, which is typically erythromycin. It's this very personalized approach based on location, allergies, pregnancy status.
Mm.
You have to consider it all.
Definitely not one size fits all. Okay, shifting again to another common but highly contagious superficial infection, impetigo.
Ah, the honey-crusted lesions.
Exactly. What's the first line strategy here? And there's a crucial public health rule mentioned too.
Yeah, for impetigo, the first line approach is actually moving more towards topical hydrogen peroxide now.
Hydrogen peroxide. Interesting.
Yeah, it's effective, and importantly, it helps minimize the risk of antibiotic resistance that you get with widespread use of topical antibiotics like fusidic acid.
So hydrogen peroxide first, if that's not enough.
Then you might step up to a topical antibiotic like
Why?
fusidic acid. It used to be first line more often.
Okay. And what if it's really widespread or just not responding to topicals?
Then you have to go to oral treatment. Yeah, typically oral flucloxacillin.
Flucloxacillin again.
Yep. And the same caveats apply as with cellulitis. If they're non-pregnant and allergic to penicillin, you'd use clarithromycin. If they're pregnant, then erythromycin again.
Got it. And the public health note, the school rule.
Oh, right. That's super important for stopping outbreaks.
Okay.
The rule is the child must stay home from school or nursery until the lesions are completely dry and crusted over. Or, the alternative is, they can return 48 hours after starting antibiotic treatment.
48 hours after starting treatment. That's the key time frame.
Exactly. Whichever comes first, dry and crusted, or 48 hours post-treatment start.
Okay, very practical. Let's pivot now into section 2, focusing on hair loss, or alopecia. The notes seem to draw a clear line between non-scarring, where hair can regrow, and scarring, where it's permanent.
Yes, that distinction is fundamental. Non-scarring alopecia offers hope because the actual hair follicle structure isn't destroyed. Alopecia areata is a classic example.
Areata, that's the patchy loss, right?
Yes, often round patches. It's fundamentally an autoimmune condition,
Mm.
and it's often linked with other systemic issues like thyroid problems or sometimes just low iron deficiency.
And the outlook?
Generally pretty good for alopecia areata.
Mm.
Most people see regrowth within about a year. Management usually involves things like topical corticosteroids or minoxidil to help stimulate regrowth.
Okay. Then there are types of hair loss linked more to life events or psychological factors.
Exactly. You have telogen effluvium. That's basically the hair cycle getting disrupted by stress. The hair shifts prematurely into the resting or telogen phase and then sheds.
What kind of stress triggers that?
It's usually a major physiological shock. Things like severe illness, major surgery, childbirth, even significant emotional trauma. The key is identifying that trigger, because usually once the stressor is removed or passes, the hair loss resolves on its own.
So that one's often temporary.
Often, yes. Then, completely different, you have trichotillomania. This isn't really a medical hair loss condition in the same way. It's psychiatric, it's compulsive hair pulling, often unconscious.
Right. And the notes also flag some perhaps surprising drug tires for hair loss. It's not just chemo, is it?
No, far from it. While cytotoxic chemotherapy is obviously a major cause, clinicians really need to be aware of other common medications. The list includes things like colchicine, often used for gout,
Colchicine. Cool.
arbamazole, which is used for hyperthyroidism, even clexane or enoxaparin,
Uh-huh.
a very common blood thinner.
Wow, Clexane too.
Yep. Sometimes just identifying and stopping the offending drug, if possible, is the cure for the hair loss. Finding it in the patient's history is key.
Okay, now let's talk about the other side. Scarring alopecia. This is the permanent damage category. What defines this clinically? What's the prognosis?
Scarring alopecia, or sometimes called cicatricial alopecia, is where there's been irreversible damage. An inflammatory process has actually destroyed the hair follicle structure itself and replaced it with scar tissue.
So no way for hair to grow back there.
Sadly, no. The prognosis is definitive. No hair regrowth is possible in those scarred areas.
And what causes this type of permanent damage?
It's usually caused by severe insults to the scalp. Things like physical injury burns, major trauma, therapeutic interventions like radiotherapy, and also some serious inflammatory skin diseases that affect the scalp, like lichen planus or systemic lupus erythematosus, SLE.
So diagnosing scarring alopecia, it sounds like it triggers a much more urgent workup.
Absolutely. You need to figure out the underlying cause quickly, because some of those causes, like lupus or lichen planus, need systemic treatment themselves.
Right. Okay, moving on to fungal infections. Let's spend a moment on Tinea capitis, that's scalp ringworm, because the management seems really specific depending on the exact fungus involved.
Yes, Tinea capitis is a perfect example of needing targeted therapy. It's usually caused by one of two main types of fungi, either Trichophyton tonsurans or Microsporum canis.
Trichophyton or microsporum. Got it.
Now, regardless of which one it is, the first step is usually the same. Use ketoconazole shampoo for the first couple of weeks.
Ketoconazole shampoo first. Why?
It mainly helps to reduce the shedding of fungal spores, cutting down on contamination and spread to others while you're waiting for the oral treatment to work.
Okay, so the shampoo is step one, but then the oral treatment path splits quite dramatically based on which fungus it is. Let's start with the one that has those serious warnings.
Right, that would be Microsporum canis. If that's the culprit, the treatment requires griselfulvin.
Griselfulvin.
Yes, and this drug comes with some really significant and absolutely necessary reproductive warnings. It has potential teratogenic effects, and it sticks around in the body for a while.
Okay, what are the specifics?
The counseling has to be very clear. Men taking it need to be told to avoid fathering a child for 6 months after stopping the drug, or use reliable contraception like condoms throughout that time.
6 months for men.
Wow. Yes, 6 months. And women must avoid pregnancy during treatment and for 4 weeks after stopping. It's strictly contraindicated if the woman is already pregnant or breastfeeding. That 6-month duration for men is a really significant point, easy to miss, and crucial for patient counseling.
Absolutely critical detail. Okay, how does the management differ if it's the other main fungus?
If the infection is caused by trichophyton tonsurans, then the required oral treatment is terbinafine.
Terbinafine.
Yes. Now, terbinafine also needs some monitoring, usually liver function tests, but it doesn't carry those same prolonged, complex reproductive warnings. So the management path is generally simpler from a counseling standpoint.
So getting the fungal culture or identification right at the start is absolutely essential before starting oral meds.
Cannot be overstated. It dictates the drug, the warnings, the duration. It's critical.
Okay, now we dive into section 3, which I have to say I find really fascinating. This is the systemic clues part, where the skin is basically shouting for help for other organs. Let's start with erythema nodosum, or EN.
EN. Classic presentation. Painful, tender, red nodules, usually on the shins, often bilateral.
ENs, okay.
They typically resolve on their own in about 6 to 8 weeks, which is good. But the reason they're significant is they often represent an inflammatory reaction to some underlying systemic trigger.
What kind of triggers?
Well, some causes are relatively straightforward. Pregnancy can trigger it, a recent strep throat infection, certain drugs like penicillins or sulfonamides. But the real clinical aha moment comes when EN points towards more chronic, serious diseases.
Right, this is where we look for those specific combinations of symptoms that really narrow down the diagnosis. What are those key patterns?
We look for the company it keeps. So if you see erythema nodosum plus oral ulcers and genital ulcers, that clinical picture points very strongly towards Behçet's disease.
Behçet's, a type of vasculitis.
Yes, a systemic vasculitis. Now, another pattern. If EN shows up alongside bloody diarrhea and abdominal pain, you need to investigate immediately for inflammatory bowel disease, especially Crohn's disease.
Crohn's, okay. And the notes mention specific links to sarcoidosis too, needing careful history taking, especially about origin and other symptoms.
Absolutely. Sarcoidosis is a multi-system inflammatory condition. So if EN appears together with a cough, suggesting lung involvement, and uveitis, which is inflammation inside the eye, especially if the patient is of African origin, that cluster is known as Hereford syndrome.
Hereford syndrome. EN, cough, uveitis, African origin.
Right. There's another, often more benign sarcoidosis link called Lofgren syndrome. That's the triad of erythema nodosum, joint pain arthralgia, and typically bilateral hilar lymphadenopathy seen on a chest X-ray.
Lofgren syndrome. EN, joint pain, swollen lymph nodes in the chest.
Exactly. Recognizing these patterns can save enormous diagnostic time and lead to the right investigations much faster.
It's a powerful reminder that just looking at the skin isn't enough. You need the whole picture. Okay, moving to dermatitis herpetiformis. This one is almost universally taught as being linked to what major gut condition?
Yeah, this is the textbook example of a skin manifestation of celiac disease.
Celiac disease.
Dermatitis herpetiformis presents as these incredibly itchy, grouped blisters, often on the elbows, knees, back, and buttocks. The link to celiac is incredibly strong, often confirmed by finding specific genetic markers like HLA-DR3 and HLA-DQ8.
And because it's driven by an immune reaction to gluten?
Exactly. The management has to be systemic first, not just topical creams for the itch.
So what's the priority?
First-line management is absolutely mandating a strict gluten-free diet. That often makes the rash disappear completely over time.
Diet first.
Diet first. There's a drug, dapsone, which is anti-inflammatory and can help with the itching, but it's really second line. It's used more for symptom relief while you're waiting for the gluten-free diet to kick in. It perfectly shows how a skin issue can be an allergy to something eaten.
Fascinating. Okay, let's talk about potentially the scariest reactions in dermatology. Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TERO-IEN. We really need to stress how severe these drug-induced reactions are.
Oh, these are true medical emergencies. Often need management in an intensive care or burn unit setting.
Burn unit, wow.
Yes, because the skin detachment is so widespread. The main difference between them is just the percentage of body surface area affected. SJS involves less than 10% detachment, 10N is over 30%, and there's an overlap in between. And what does it look like? You see widespread blistering, and then the skin starts sloughing off. It also affects mucous membranes, eyes, mouth, genitals. It's absolutely devastating. And it's vital to recognize the common drug triggers, because stopping the offending drug immediately is the single most important thing you can do. Okay, what are the main drug culprits we need to have on our radar? Unfortunately, the list includes some very commonly prescribed medications. You've got NSAIDs like ibuprofen or naproxen, allopurinol used for gout, antibiotics like penicillins and sulfonamide, and then a really important group, certain anti-epileptic drugs, particularly lamotrigine, carbamazepine, and phenytoin.
So if a patient develops a severe blistering rash while on one of those drugs,
SJSN has to be top of your differential diagnosis, immediate suspicion, immediate action. Got it. Okay, on a less severe note, but still common, what about simple urticaria or hives? Any common drug triggers there? Yes, while much less dangerous. Urticaria is very common. The usual suspects for drug-induced hives include penicillin, again, aspirin, other NSAIDs, and opiates. These reactions are typically driven by histamine release.
okay. And finally, in this section, let's look at those fatty deposits, xanthomas and xanthelasma. What metabolic issues are they signaling?
Right, these little fatty bumps are powerful visual clues about lipid problems. Eruptive xanthomas, they look like small reddish-yellow bumps, often popping up suddenly or strongly linked to extremely high triglyceride levels,
Very high triglycerides.
which immediately flags a significantly increased risk for ischemic heart disease, IHD.
Okay, and xanthelasma, those yellowish patches around the eyes.
Xanthelasma are quite common, especially as people get older. They're cholesterol deposits. While often just related to general high cholesterol or even normal lipids, they have a specific association noted with primary biliary cholangitis, PBC, which is a chronic liver disease. So we're thinking about PBC if you see them.
PBC link. Interesting. And what's the subtle point about tendinxanthoma?
Tendinxanthomas, these are deeper deposits you might feel or see in tendons. Often the Achilles tendon, they definitely signal high cholesterol. But the notes add a layer if the patient also has high uric acid levels in their blood tests.
High cholesterol and high uric acid.
You have to consider gout as well.
Yeah.
Because sometimes the deposits might be tophi from gout, or the two conditions might just be coexisting. It's about putting the clinical sign together with the lab results. Always integrate.
Good point. Okay, that brings us very nicely into section 4, chronic conditions. We'll focus on eczema, psoriasis, and rosacea. Starting with eczema, there's a vital practical tip about applying treatments.
Yes, this is fundamental for getting the best results, and something patients often get wrong. You should always apply the emollient, the moisturizer, a good 30 minutes before you apply the topical steroid cream.
30 minutes before, why the gap?
Two main reasons. First, the emollient hydrates the skin and helps repair the skin barrier, making it healthier. Second, applying it 30 minutes beforehand prevents the emollient from diluting the steroid cream. You want the steroid at full strength to penetrate effectively.
Ah, avoids dilution. Makes sense. Okay, now let's dive into a specific type. Seborrheic dermatitis in adults. Common, flaky, often on the face and scalp. But the notes point to two major non-dermatological red flags.
Right. Seborrheic dermatitis is that chronic inflammation thought to be related to the yeast Malassezia furfur. You see it in oily areas, scalp, eyebrows, sides of the nose, behind the ears. Standard treatment is often medicated shampoos for the scalp, maybe topical ketoconazole for the face.
Okay, standard stuff, but the red flags.
If the condition is unusually severe, doesn't respond well to standard treatment,
Mm.
or keeps coming back frequently and aggressively, that should trigger immediate systemic investigation.
And what are the two big systemic conditions we need to screen for in that situation?
First, especially if it's severe or recurrent, you absolutely must check the patient's HIV status. Uncontrolled, widespread seborrheic dermatitis can be one of the earliest skin signs of underlying immunosuppression from HIV.
HIV check. Crucial. And the second one?
Second, particularly in the elderly population, severe or new onset sebderm is also associated with Parkinson's disease.
Parkinson's, wow, okay.
Yeah. So recognizing these links can turn a seemingly routine prescription for flaky skin into a potentially life-saving screening opportunity.
Definitely elevates the importance. Are there other eczema-related red flags mentioned that warrant referral?
Yes, a few specific scenarios. If eczema appears specifically around varicose veins on the lower legs, that might be stasis dermatitis due to poor circulation and needs a vascular assessment. Eczema that's localized just around the nipple, particularly if it's unilateral, needs urgent investigation to rule out Paget's disease of the breast, which is a form of breast cancer presenting on the skin.
Paget's disease. Mustn't miss that.
Absolutely. And finally, in children who have severe eczema, along with recurrent serious infections, you need to think about rare underlying immunodeficiency syndromes, like Wiskott-Aldrich syndrome.
Okay, important flags there. Let's switch gears to psoriasis now, specifically plaque psoriasis, the most common type. The notes lay out a very structured, step-by-step management plan. How does that begin?
Right. For plaque psoriasis, the initial approach, step one, is usually a combination therapy. You use calcipotriol, which is a vitamin D analog,
Vitamin D analog.
plus a topical steroid, prescribed together for about 4 weeks. But the crucial instruction is they need to be applied at different times of the day.
Oh, not mixed together. Why separate application times?
Well, they work differently. The steroid tackles the inflammation quickly. The vitamin D analog works more slowly to reduce the rapid skin cell turnover that causes the thick plaques. Applying them separately seems to maximize their individual effects and might reduce potential inactivation or irritation.
Okay, combination, but applied separately for 4 weeks. What happens if that's not enough? How do we move through the steps?
It's all based on response and also managing long-term steroid risk. So, if step 1 doesn't give enough improvement after 4 weeks, you typically continue that same combination for another 4 weeks. That's step 2.
Then a month of the combo.
Right. Then, because we want to minimize long-term potent steroid use due to side effects like skin thinning, step 3 involves switching to only the calcipotriol, the vitamin D, but using it twice a day for maybe up to 12 weeks, trying to maintain control without the steroid.
I see. Stepping down the steroid dependence.
Exactly. Only if that whole sequence fails, after really trying to maximize the steroid-sparing approach, do you move to step 4. And that's when you bring in options with potentially more side effects or complexity, like using a potent steroid twice daily again, or introducing coal tar preparation.
Coal tar. Okay.
But you have to be careful with, avoid the face, or another older treatment called dithronol.
Right. So it's a clear escalation based on response and safety. What about less common types of psoriasis, like guttate psoriasis?
Guttate psoriasis, that presents differently small, teardrop-shaped spots, often appearing quite suddenly all over the body. It's frequently triggered by a preceding infection, usually a streptococcal sore throat.
Strep throat trigger.
Yeah. And the really key management point for guttate psoriasis is that it often requires no specific treatment for the psoriasis itself. It tends to resolve spontaneously over a few weeks or months once the triggering infection is gone.
Interesting. No treatment needed usually. And flexural psoriasis, the type in skin folds.
Right. Flexural psoriasis affects areas like the armpits, groin, under the breasts. Because these are sensitive skin areas prone to thinning from steroids, you start with only a mild or maybe moderate strength topical steroid. Weaker steroid first. Yes. And if that doesn't work well enough, instead of escalating to stronger steroids, which carry more risk in these areas, the next step is often to add a non-steroidal topical calcineurin inhibitor, like pimecrolimus or tacrolimus cream, usually for about 6 weeks.
Okay, different approach for the folds. Good to know. Let's finish this section with rosacea. The management here seems very tailored to the specific symptoms the patient has.
Absolutely. Rosacea isn't just one thing. It's a chronic inflammatory condition, often involves vascular reactivity. Key features can include persistent facial redness, flushing, visible tiny blood vessels called telangiectasias, and sometimes inflammatory bumps, papules, and pustules, mainly on the central face, like cheeks, nose, forehead.
So how do you treat it based on those features?
You target the main problem. If the patient is mostly bothered by the inflammatory papules and pustules.
The spots.
Yeah, the spots. First-line treatment now is often topical ivermectin cream.
Ivermectin. Interesting choice.
Yeah, it's thought to work partly by reducing Demodex mites, which can play a role in rosacea inflammation, and it also has direct anti-inflammatory effects. If ivermectin isn't enough or not tolerated, second line is usually topical metronidazole gel or cream.
Okay, ivermectin or metronidazole for the spots. What about the redness and flushing?
If persistent redness or frequent flushing is the main issue, you can prescribe brimonidine gel. It's an alpha agonist, basically a vasoconstrictor. It temporarily shrinks the blood vessels to reduce the redness. The effect is quite rapid but wears off.
Brimonidine for flushing. And the visible broken vessels, the telangiectasias.
For those permanent dilated vessels, topical treatments don't really work. The only truly effective long-term solution is usually laser therapy or intense pulsed light IPL treatment to specifically target and destroy those vessels.
Laser for telangiectasias. Okay, and we saved the most dramatic presentation for last. That cauliflower nose.
Ah, rhinophthalma. Yes, that's a more severe advanced form of rosacea. It involves thickening in the skin and enlargement of the sebaceous glands, primarily on the nose, leading to that bulbous, irregular appearance.
And the management.
If rhinophyma is present, it really signals severe, long-standing disease. It doesn't typically respond well to medical treatments. It requires a referral, usually to a plastics or dermatological surgeon, for procedures like dermabrasion or laser ablation to physically reshape the nose.
Surgical referral for rhinophyma. Got it. Okay, moving to our fifth section. This is crucial. Understanding the differences between the main skin cancers. Basal cell carcinoma, BCC, squamous cell carcinoma, SCC, and malignant melanoma. Presentation and prognosis are key.
Differentiating these is absolutely critical because their potential to spread, their metastatic potential varies hugely. Let's start with BCC.
Okay, BCC.
Basal cell carcinoma. This is the most common type of skin cancer and generally the least dangerous. It's typically a slow grower.
Slow grower, less dangerous. What does it look like?
Classically, it presents as a pearly pink or sometimes skin-colored nodule, or maybe a flat plaque. Key features to look for are that classic, rolled, slightly raised edge. You might see tiny blood vessels, telangiectasias running across its surface.
Rolled edge, visible vessels.
Yes. Often, there's some central ulceration or crusting, but importantly, the ulcer usually doesn't involve the entire lesion, especially not the rolled border. And crucially, BCC tends to be locally invasive, but very rarely metastasizes. It doesn't typically produce satellite lesions nearby.
Okay, pearly, rolled edge, slow, rarely spreads. Now, SEC squamous cell carcinoma, that's the more dangerous cousin, right? Faster growing.
Exactly. SEC behaves more aggressively and has a higher risk of metastasis compared to BCC. The key feature is often its rate of growth. SEC lesions tend to grow much more rapidly, sometimes becoming quite large over weeks or months.
Faster growth. What else distinguishes it visually?
It often looks more irregular, maybe more crusted or scaly than a BCC. Ulceration is common and might cover most of the lesion's surface, looking more destructive. SEC can sometimes present as a persistent, non-healing ulcer, or even as a firm, projecting cutaneous horn. And unlike BCC, SEC can develop satellite lesions around the main tumor.
Okay, faster, more ulcerated, potential satellites. The notes also list several conditions that can actually transform into SCC, premalignant conditions or chronic inflammation.
Yes, that's important. SCC often arises from chronically damaged or inflamed skin. Key conditions that carry a risk of progression to SCC include actinic keratosis, sun-damaged spots, Bowen's disease, which is essentially SCC in situ, confined to the epidermis.
Bowen's disease, right? Treated with Effudix sometimes.
Yes, topical fluorosil Effudix is a common treatment for Bowen's, trying to prevent it becoming invasive SCC. Other risk factors include chronic non-healing wounds or ulcers, areas of old burn scars, and certain chronic inflammatory skin conditions like lichen sclerosis, sickness around the genitals.
Lichen sclerosis again.
Yes. Also, conditions mentioned less commonly perhaps, but listed. Chronic schistosomiasis infection can lead to bladder SCC, but it sometimes gets mentioned. Aggressive PUVA therapy for psoriasis carries a risk, and erythema, ab igne, that mottled pigmentation you get from chronic heat exposure, like from a hot water bottle or laptop, all increase SCC risk.
Lots of potential precursors. Okay, now for malignant melanoma. This is the one with the highest mortality risk, the one triggering urgent referrals. What's the single most critical factor for prognosis?
Unquestionably, it's the Breslow depth.
Breslow depth.
Measured in millimeters. Yes. It's a microscopic measurement of how deep the melanoma tumor has invaded vertically into the skin layers, from the top of the granular layer down to the deepest point of invasion.
And why is that number so critical?
Because it directly correlates with the risk of the melanoma spreading, metastasizing to lymph nodes and other organs. The deeper the invasion, the higher the risk. A Breslow depth of, say, 4 millimeters or more generally indicates a significantly worse prognosis.
Okay, depth is paramount. Is there a tumor marker used?
Yes. For monitoring melanoma after diagnosis and treatment, the tumor marker S100 is often used.
S100. Got it. And the decision to make that urgent 2-week wait referral in the UK system relies on a clinical scoring system. How does that work?
Right. It's designed for rapid identification of potentially suspicious pigmented lesions. The goal is not to miss melanomas. A score of 3 points or more triggers the urgent referral.
Score of 3 or more? What are the criteria?
They're divided into major and minor factors. The major factors are worth 2 points each. These are significant changes in size, irregular shape, or irregular color, like multiple colors, black, blue.
Size, shape, color, 2 points each.
Yes. Then the minor factors are worth 1 point each. These include diameter greater than 7 millimeters, inflammation around the lesion, oozing or bleeding from the lesion, or altered sensation like itching or pain.
Diameter 7 millimeter, inflammation, oozing, bleeding, altered sensation, 1 point each.
Exactly. So you add up the points based on the lesion's features. If it hits 3 or more, it needs that urgent specialist assessment. It's a system designed to catch what is, I believe, the 7th most common cancer in the UK quickly.
That scoring system is incredibly helpful for practical application. Okay, let's wrap things up with our final section, Section 6. Diagnostic pointers and practical guides. Let's start by untangling 2 conditions with similar names, lichen planus and lichen sclerosis.
Right. Easy to confuse, but quite different. Lichen planus LP, think of the 4 Ps. Purple, polygonal, meaning angular shape. Pruritic, itchy, papules, small clump.
Purple polygonal pruritic papules, LP.
Exactly. A classic sign, especially if it affects the mouth or genitals, is Wickham striae, these fine, white, lace-like lines on the surface. LP can also affect nails, causing longitudinal ridges and brittleness. Importantly, lichen planus, particularly on the vulva, is a risk factor for developing vulval cancer over time.
Okay, LP linked to Wickham striae, nail changes, and vulval cancer risk. Now, lichen sclerosus, LS, often seen in older people.
Yes, LS typically presents as white, sort of ivory-colored, thinned, atrophic patches or plaques. Most common on the genitals, especially in postmenopausal women, but can occur elsewhere. In men, when it affects the foreskin and glands, it's often called valinitis serotica obliterans, BXO.
BXOs is LS in men.
Essentially, yes.
Mhm.
And like LP, lichen sclerosus also carries a significant risk factor for malignant transformation, specifically into squamous cell carcinoma, SCC, particularly in the genital area.
SEC risk with LS. And the management for BXO.
It needs potent treatment.
Yeah.
Usually potent topical corticosteroids like Dermavate, clobetasol, used consistently for several months, often up to 6 months initially. If that doesn't control it, referral for consideration of circumcision is often the next step.
Okay, potent steroids or surgery for BXO. We should also quickly mention the Koebner phenomenon. It sounds like a fascinating observation about trauma-triggering skin conditions.
It really is. The Koebner phenomenon describes when lesions of a specific skin disease appear at sites of injury or trauma to previously unaffected skin.
So you scratch yourself and the rash appears in the scratch.
Exactly. The trauma somehow triggers the underlying disease process to manifest locally. It's famously seen in psoriasis, but also in lichen planus and lichen sclerosus. It can also occur with infections like molluscum contagiosum and warts, and even in vitiligo. It tells us that physical factors can definitely influence where these conditions appear.
Interesting interaction. Okay, quick clues for annular lesions, those ring-shaped ones.
Ring shape always makes you think.
Yeah.
The history is key. If a patient comes in with an expanding annular reddish lesion, especially after being outdoors in a grassy or wooded area, potentially with tick exposure,
Lyme disease.
you have to strongly suspect Lyme disease presenting as erythema migrans. Needs urgent treatment. On the other hand, if the patient has a known history of eczema and they develop a coin-shaped or ring-like plaque of eczema, that's likely discoid eczema. So context and history are everything.
Got it. Let's quickly look at nails, again, those little diagnostic windows. What do specific changes point to?
Nails give great clues. Koilonychia, that's spoon-shaped nails, where they become concave, is the classic sign of iron deficiency anemia.
Spoon nails, low iron.
Yes. Nail petting, little depressions in the nail plate, especially combined with oncolysis, where the nail lifts off the nail bed, that combination is highly suggestive of psoriasis.
Pitting plus onycholysis equals psoriasis.
Right. And as we mentioned with LP, longitudinal ridges and brittle, fragile nails often point towards lichen planus affecting the nails.
Ridges plus brittle, lichen planus. Good summary. And finally, a practical point on nail infections, paronychia, infection around the nail fold.
Yes, common problem. For simple localized paronychia, maybe just a bit red and swollen at the side of the nail, initial management is often conservative. Warm salt water soaked several times a day, plus maybe a topical antiseptic or antibiotic like fusidic acid.
Soaks in topical first.
Yeah. But if the infection looks more extensive, if there's significant pus, a paronychia abscess, or if there's surrounding redness spreading up the finger suggesting cellulitis, then you need oral antibiotics. Usually flucloxacillin or chlorthromycin if penicillin allergic.
Okay, step up to orals if it's worse. Now, we saved one of the most critical, don't miss systemic red flags for last in this section, the Lesser-Trela sign.
Ah, yes. Absolutely vital diagnostic clue. Seborrheic keratosis, those common waxy, stuck-on-looking brown marks people get as they age, are themselves completely benign, harmless.
Right, very common.
But the Lesser-Trela sign is different. It's defined by the sudden eruption and rapid increase in the number and size of multiple seborrheic keratoses all over the body, often accompanied by itching.
Sudden, rapid appearance of many seb case.
Exactly. When you see that rapid change, that sudden explosion of lesions, it's a huge red flag. It's considered a paraneoplastic syndrome, a sign triggered by an underlying internal cancer. It requires urgent referral for investigation for malignancy.
What kind of cancer most commonly?
Most frequently associated with gastrointestinal cancers, especially gastric adenocarcinoma, stomach cancer. The theory is the tumor releases growth factors that stimulate the rapid development of the SEV case. That speed of onset is the absolute key.
Lesser-Trela, urgent cancer workup, especially stomach. Wow. What a perfect example of that skin systemic link we aim to find. And just to ensure safe practice, let's quickly revisit the practical guide to using topical steroids, the fingertip unit, or FTU.
Yes, the FTU is essential for guiding patients on how much potent topical steroid to actually apply. Using too little means the treatment won't work effectively. Using too much increases the risk of side effects like skin thinning, atrophy, or even systemic absorption if used over large areas for a long time.
So how is one FTU defined?
One fingertip unit is the amount of cream or ointment squeezed out of a standard tube onto the adult index finger, from the very tip down to the first skin crease.
Tip to first crease. And how much area does that cover?
One FTU is roughly enough to treat an area of skin equivalent to the size of 2 adult palms, including the fingers. Or you can think of one FTU covering one entire adult handprint, palm and fingers.
Okay, one FTU equals roughly 2 palms or one handprint. How does that translate to larger body parts?
The notes give helpful estimates. For example, covering the entire face and neck would require about 2.5 FTUs.
2.5 for face and neck.
An entire arm might take 3 FTUs. A whole leg and foot takes about 8 FTUs. The whole trunk, front and back, needs around 14 FTUs.
Leg and foot 8 FTUs. Trunk equals 14 FTUs.
Exactly. And for prescribing purposes, it's useful to know that a standard 100-gram tube of cream is generally enough to cover the entire body of an adult twice daily for about a week, or perhaps both legs twice daily for about 2 weeks. Knowing these equivalents helps ensure patients use the right amount for effective and safe treatment.
Incredibly practical. Okay, well, we have definitely completed a comprehensive deep dive today. We've gone from the really severe protocols and serious drug warnings around oral isotretinoin.
And the fungal warnings with crisafulvin?
Right. All the way to those really surprising connections, like remembering that recurrent seborrheic dermatitis needs an HIV check, or that dermatitis herpetiformis is basically shouting celiac disease.
Yeah, the core takeaway, I think, is crystal clear. Dermatology is very rarely just skin deep. Those management protocols aren't arbitrary. They're carefully built to handle complex drug risks and systemic possibilities.
Definitely.
And the specific ways things present on the skin, where the cellulitis is, what type of alopecia it is, whether those seb caves appeared overnight, these are often direct clues to major systemic health problems, sometimes even underlying cancer risk.
Indeed. We saw how physical trauma, the Kogner phenomenon, can actually trigger diseases like psoriasis to appear in specific spots, and how a sudden burst of seemingly harmless skin bumps, the Leser-Trelot sign, can be the first warning of a hidden cancer deep inside, like in the stomach.
Amazing connections.
So the provocative thought we want to leave you with today is this. Thinking about these links, what other superficial signs, maybe a subtle change in color, a small lesion that doesn't quite heal, a patch of persistent inflammation might we be overlooking in our everyday observations, either on ourselves or others, that could actually warrant a deeper clinical look into the body's internal workings?
It makes you think, doesn't it?
It really does. We encourage you to keep observing those connections, keep thinking critically until our next deep dive.